I'm Justin Robinson, an integrated CT resident at the University of Maryland and current Kirkland Ashburn Congenital Research Fellow at Cleveland Clinic. I have with me today Dr. David Zapata, a cardiac surgeon at the University of Maryland, and today we will be discussing the topic when blood is not an option. Thank you for joining me today, Dr. Zapata.
Yeah, thanks for having me, Justin. I believe this is a crucial discussion, so I'm looking forward to talking about it today. Justin, why don't you start by giving us all a brief overview of the history and current practices in blood conservation?
Yeah, historically, the search for alternatives to blood transfusion began as early as World War II, and this was driven by logistical challenges of blood management and the battlefield conditions. And nearly one-third of battlefield deaths were due to hemorrhage, highlighting the need for effective substitutes.
Exactly. Like many other important innovations in healthcare, the early stages of transfusion alternatives came with the practice of wartime medicine. These conditions led to the need for a blood alternative with properties such as indefinite storage at room temperature and the elimination of the need for cross-matching.
This led to the creation of blood conservation programs within medicine. And at Cornell University, they pioneered blood conservation programs and studies beginning in 1993. This is the origin of strategies such as high-dose erythropoietin for patients with inadequate red cell mass preoperatively, cell-saver utilization, and intraoperative autologous donation and retrograde autologous priming, or RAP.
I find it impressive that some of these techniques that were developed specifically for these patient populations that couldn't have blood are now being used generally today. I think this speaks to how these techniques minimize the overall risk associated with blood transfusions, such as allergic reactions, blood type mismatches, and infections. These techniques also allow us to support patients who may otherwise refuse blood for personal or religious reasons. Now, Justin, I think it's best to consider the phases of care in which we would apply various blood conservation strategies. A lot of the details that go into helping these patients without the benefit of blood availability are dealt with in the preoperative and the intraoperative phases. Can you think of some strategies that we use in the preoperative phase to prepare patients for surgery?
Yeah, in the preoperative phase, we optimize our patients in the following ways. Stop all antiplatelet therapy, such as aspirin, except in patients with acute coronary syndrome. Minimize phlebotomy. Identify which, if any, products each individual patient might be willing to accept, since every person may vary in their opinion on what they would allow. In patients with anemia or that are high risk for anemia, administer preoperative EPO or stimulating agents and iron supplementation several days prior to cardiac operations to increase red cell mass.
Yeah, that's great. I think all of these methods allow for optimization prior to surgery. And there are quite a few tips to highlight in the intraoperative phase, which we'll go through now. In the beginning of the case, the surgeon can work with the anesthesiologist to implement an acute normovolemic hemodilution or ANH strategy. This involves removing whole blood from the patient after inducing anesthesia with readministration of that blood post bypass. This has led to a 20 to 30% reduction in transfusion rates and shorter hospital stays. Also, anesthesiologists will use TXA to reduce bleeding and transfusion requirements. Now, can you highlight any strategies that we may use while going on and while on cardiopulmonary bypass?
Yes, there are a few. The first is RAP, Avast circuitry before going on bypass to minimize hemodilution. We also practice blood preservation using either pump salvage blood or red cell salvage for reuse. Finally, we employ modified ultrafiltration during bypass to further minimize hemodilution. And during the surgery, it is important to minimize use of lap sponges and Ratex that can absorb blood and make it harder to recollect. Finally, after the bypass run, we have a slightly lower threshold to use medications such as DDAVP, even PCC, recombinant factor 7, in addition to routine hemostatic agent application. Individual patients may also be willing to receive FFP.
Good. And finally, I'll just highlight that in the postoperative phase, we're pretty judicious about the use of antiplatelet or anticoagulation agents. You want to be sure that the bleeding has subsided before utilizing these medications. And in patients who have received coronary artery bypass grafting, for instance, we may delay or even abandon the administration of Plavix after surgery and rely on a variable dose of aspirin alone as they recover.
Got it. Well, it's clear that patient-centered decision-making and interdisciplinary collaboration are key in implementing these strategies effectively to ensure optimal outcomes while respecting patient choices.
Mhm. Yeah, so in conclusion, as medical professionals, it is vital to continue exploring and refining these approaches to ensure that we provide the safest and most effective care possible, particularly in situations where blood transfusion is not an option.
Well said. Thank you for discussing this important topic today, Dr. Zapata.
Yeah, my pleasure.